All right, welcome to the live stream here at Deuk Spine. This patient presents to us with back pain. She's had it for a long time, and she had originally had her discs treated. Let's do some more. She had herniated discs, and now she presents with facet joint pain. And the facet joint pain is really bothering her. She's getting more active now that she had her discs fixed. So we're treating the facet joints today. She has facet joint pain on both sides, L3-4, L4-5, and L5-S1. Right now I'm infiltrating. I'm giving her some medicine under her skin to ease the discomfort of the procedure. I'm going to go ahead and start on the left side of the patient. I'm going to access the, we're fixing the L3-4, 4-5-5-1 facet pain. So I have to target the junction of the transverse process and the pedicle of L3 shot, right where the arrow is basically. And there we are, shot. All right, so we're in the almost perfect position. Now it's probably perfect, shot. Yeah, that's really good right there. So that's our first target. Remember, to treat the facets, you want to get the nerve above and below the facet joint. And that's what we're going to do. And these nerves are not the same as a nerve root. We're not targeting a nerve root, okay? Please don't think we're going and burning a nerve root. We're actually burning a little nerve called the medial branch of the dorsal ramus. Shot. And if I can get to where we need to be, that's closer. But you can't be close. You have to be exactly on the spot. And that's why you use an X-ray to navigate and get to exactly where you need to be. That's exactly where we need to be, right there. That is the perfect spot. And once I get there, it's amazing. I get on the bone and then her muscles tighten up and it literally pushes my bovie tip away. It's pretty interesting. Because we're not under general anesthesia. No, I don't know. Do you think it would matter? I don't know if it's reflex or if it's conscious. That's a great question. Let's try a little bit deeper, see if it helps, shot. So I'm pretty much where I need to be. Let's try, shot. Feels a little bit too low. Shot. I'm feeling the wall of the facet. Shot. I think that's as perfect as it gets. All right, I think we got it. Pretty darn good. Shot? Yeah, that's really pretty good right there. Let me see, she's moving a little bit, so making it hard. She's moving things around. I just want to see if, yeah, that's perfect. If we get better muscle control with a little bit deeper, you know? Shot. That should be it. Okay, next we're going to move down to the L4 on her left side. You go ahead and position the fluoro. Meanwhile, I'll put the needle and just get started. Any questions for us as we're doing a Deuk plasma rhizotomy, which is a rhizotomy, but a really souped up rhizotomy. Souped up in the sense that we are, with an RFA, you're using a skinny little probe to do the rhizotomy. Here, I think I see it. It's just below that shelf for the bone spur. We're too high for it right here. Yeah, it's a little, yeah, right to the left, just a little bit, right there. A little bit to the right. Down a little bit. Perfect. Right there. Let's get shot. See where we are.
No current questions.
Fine. Shot. All right. That looks really good right there. I like that. Try to numb it up a little more, Luis.
Okay.
Let's put a little more. Well, we're going to give a little more numbing in that area and pull up just a little bit and a little more numbing. Yeah. That way, maybe if we numb the nerves, then she won't have the muscle contraction. Right? You mean wait after we inject, or do you mean wait for you to do something?
After you inject.
But isn't there lidocaine?
Yeah, lidocaine, 7 minutes.
What?
Look it up. 7 minutes.
Onset is 7 minutes?
7 minutes. Peak effect. Peak onset, 7 minutes. Surgeons think it's 7 seconds. It's really not. Anesthesiologists say 7 minutes.
Got it. See, I'm learning new things all the time from my anesthesiologist, Dr. Berndos.
I learned from you too.
Well, it's mutual. Shot. So basically what I'm learning here is that, shot, the onset of effect for some of the medicines we're using is a little bit longer than we would have anticipated.
That's why I like it when Luis numbs it up.
Shot?
As soon as we get into the room.
Yeah. Well, we can talk about that later. Shot? Trying to get down to where we need to be. And remember, we're using an X-ray to navigate. Too lateral. I feel the facet. Shot. 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 That's really good right there. I can make it stay. Shot. Nope, see, it's already moved. Shot. A lot of the movement is due to the patient's muscles twitching. How's she doing? Shot. That seemed to be a little bit better, right? Shot. 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 I feel bone, but on the X-ray it just doesn't look right, you know? But I'm definitely on the TP. Shot. That's TP for sure. I think that's the spot. Shot. I think that's the spot because I'm really bumping up against the superior facet medially. I'm really just crawling along the TP. Well, that should do it. All right, that's 2 down, 2 more to go on the left side. And then we'll move over to the right side. We're going to. Shot. Come to me a little bit. You're too far to you. All right. Yeah, I see it. Show us the target. That's correct. Maybe a little bit medial to that, but that's pretty darn good. Shot? Yep.
There?
Hold on, let me just feel the bone. Yep, we're there. Let me have the coker. All right, shot. That's pretty much perfect right there. So we're going to do a little num-num, a little Novocaine and Marcaine, numb the nerves up so that it's not as uncomfortable for the patient. That helps me because if she's comfortable, she's not twitching her muscles under the skin, because that's a big part of the problem, is all the muscle twitching. The muscle twitching causes the probe that we're using to be displaced from where I want it to be to another location, away from where I want it to be. And the procedure really requires, about 5 millimeter accuracy for the tip of the probe for the primary target location. And then, of course, you're going to burn around that about a centimeter. An RFA doesn't allow you to do that. A radiofrequency probe only allows about a 2 to 3 millimeter burn radius, which is why they don't work very well. And so not using epinephrine's made a big difference, huh? For sure. We can say for sure.
For sure.
We have a question.
Questions? Who
Yes.
says we answer questions? All right, go ahead.
This comes from Jay Mora on YouTube,
Uh-huh.
and they asked, I have annular tears on both sides of 2 discs that have not healed.
Yep.
Nucleus keeps leaking out. Why
Yep.
is that? And how does the laser spine surgery help it heal if it didn't want to heal naturally?
Yeah, the reason your tear is not healing, let's go ahead and run the video showing why the annular tear doesn't heal. The reason is because you have some jelly, nuclear jelly, stuck in it. And what the Deuk laser disc repair does is it removes that jelly, cleans the tear, gets rid of the inflammatory tissue that's causing all the pain. So it's not going to heal on its own. Nobody's annular tear will heal on its own. It's a misunderstanding to believe that your annular tear will heal itself. It won't. Shot? The annular tear will not heal itself.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
And welcome back. We're currently working on our third medial branch of the dorsal ramus at L5. Our last one will be at S1. I'm using the X-ray to verify that my burn positions are perfect, as good as we can get at least. Maybe not perfect, but as good as humanly possible. I'm okay with as good as humanly possible. good with anything less than that, though. Shot. And as you can see, if you're watching, that it takes more than one burn. And yes, it is a burn. Sorry, but that's exactly what it is. So that's why we talk about it being a burn, because it actually is a burn. You're burning a nerve that actually travels up to the facet joint, shot, and transmits pain signals from the facet joint to the brain. And so what pain signals there are is pain signals from arthritis emanating from that joint. You see, arthritis is the most common cause of joint pain. Shot. I really feel shot. Yeah, I really feel that's where we need to be as well. All right, one more to go. So the treatment for facet pain is quite interesting. We cannot get rid of the arthritis, but what we can do is get rid of the pain. And treating an arthritic joint, getting rid of the pain in an arthritic joint, it's something that doctors have been doing for 100 years. The first time doctors treated arthritis was probably with some type of medicine that's anti-inflammatory. But then we learned over time that we could treat an arthritic joint by removing the arthritic joint, fusing the arthritic joint. So a lot of the original treatment of arthritic joints done by orthopedic surgeons was designed to fuse painful joints together. And I'm not sure when the first joint fusion occurred. That's it right there. But it was probably a knee or an ankle or a hip that was the first joints fused. And once they fused the joint and stopped moving, then the pain went away. And that's when surgeons realized, and I don't think surgeons were the first ones to fuse joints. I think some patients had such severe arthritis that their joints actually fused on their own. And the surgeons probably observed that, and that the pain went away once the joint auto-fused. We call it autofusion. And then they realized that when the joints auto-fuse, the pain goes away, right? And once you understand that concept, then basically you know what needs to be done. You need to get those joints to fuse. And if you're successful at doing that as a treatment, then you can get rid of the pain that comes from an arthritic joint, okay? And that's what the first joint fusions did. They targeted painful joints, hips, knees, shoulders, and eventually went to spines. That's where spinal fusions come from. And now, for the last 20 years, spinal fusions have gotten big. And a lot of doctors are fusing spines to get rid of the disc pain, the joint pain. And it's not just disc pain they're getting rid of. They're getting rid of the disc and the facet joint pain. When you do a fusion, you get rid of both. So that's what I did for years, was just fuse people. And I got rid of their pain by fusing the disc and the facet with screws, rods, cages. And then I realized, as I got less invasive with endoscopic surgery, you didn't actually have to fuse the whole joint. You can target the actual location of the pain within the joint, which is actually once I learned that the pain came from facets and discs, then I started to zoom in on, okay, well, where is it coming from exactly? And the facets were already, somebody figured that out a long time ago. Oh, that's perfect. With the facets, the pain comes from, that's it right there. Let's get some num-num. The pain comes from arthritis in the facet joint capsule. Pain in the facet joint capsule. And then with the discs, the pain comes from the annular tear in the back of the disc. So once I realized those two things, I mean, the facets had already been done before me. And then once I learned the disc was the cause and it was the posterior annular tear, then you can target those areas with treatments, eliminate pain, and you don't have to do a fusion. You don't have to do an artificial disc. You don't have to get rid of the arthritic joint. You don't have to fuse it or cut it out like so many doctors do. You could get rid of the pain by zapping away the painful area of the joint. It's actually quite simple. There's nothing, honestly, huge about it. I'm surprised I had to be the one to figure it out, to be quite honest with you. Thought somebody smarter than me would figure it out. But the problem is they haven't, and why they haven't, I don't know. You know, things like that I don't try to logically determine at times. I just realize that's God's plan, and I'm just doing what God wants me to do. And, you know, you don't really question your role beyond initially maybe questioning. But here I am doing things I never dreamed I would be doing years ago. I knew I wanted to help people in pain, but I didn't realize that I would have to invent techniques to do that. I thought that there were much smarter people than me out there, that I've always, you know, kind of learned from other people what to do, never actually thinking that I would be the one to figure things out. But, like I said, who are we to question? Divine inspiration, divine authority. At least I know I'm not. So here I am doing things, like I said, that I never would have dreamed about doing years ago because they didn't exist and because I never saw myself as being a pioneer. I just saw myself as being someone who wanted to get people out of pain. And fortunately, I've been blessed with the ability to do that with my team. Shot? All right, so it's a little bit too low. I need to be a little bit higher up. Shot? No, that's not it either. Shot? That's a little bit better. But things are slipping around. Shot? I can't have it slipping around. Shot? Feels like it's too high. Who's making noises? Shot? Oh, and for those of you who don't know, this area right here we're working on, it's really difficult because there's something called the mammillary process, which is what I'm on right now. And it's quite literally a bump that pushes you. It's like the top of a roof. It either pushes you up or down, but it doesn't let you stay right where you're supposed to be. So it's hard to be in the right spot because the mammillary process forces you up or down, and you don't want to go up, you don't want to go down. I mean, you want to do a little bit, but not a lot. All right, that's good. We're going to move down to the next location for the medial branch of the dorsal ramus. That's what we're targeting. By the way, I've looked at the new model. That's perfect. Right there. I'll take the medicine. I looked at the new spine model we've got for the website that's coming up, and there's an interactive spine that you can play with. You, the user, can play with and rotate. It's got labels on it. And of course, one of the labels is the medial branch of the dorsal ramus, which happens to be the nerve that we're targeting with all these rhizotomies. Everybody knows that in pain management. All the doctors know what the medial branch of the dorsal ramus is. It comes off in the foramen, off of the nerve root. And that is the target of all facet joint pain treatments, like even the Deuk plasma rhizotomy. I knew I was too medial. should have known. It's tough when patients have some scoliosis because you end up having to compensate for that shot. All right, let's see our target. It's a little lateral to this. Oh yeah, and the reason why it's tough too is because you got fascia, which is the covering around the muscle. Shot. The fascia, once you poke through it, you're kind of committed to go into that area. So I'm making a little fascial hole. Shot. It's too high. Shot. We have a question?
Yes, we do. We have
Wonderful.
a question from Mike on YouTube,
We like questions. Shot.
and they asked, have
Shot.
you heard of the mild procedure for hypertrophic ligaments causing lumbar spinal stenosis?
Yes, I've heard of the mild procedure. Absolutely. Yes. We don't do the mild because it's a bad procedure. It's, in my opinion, what I call a scam. We don't do the mild procedure at Deuk Spine. It's not a good procedure. And the doctors that do it are typically not surgeons. They are pain management doctors who are trying to get some surgery money in their pockets, and they just want to make profit. They don't really care about the patient having the right surgery. In other words, no real surgeon does the mild procedure, even though it's a surgery. The reason why is because the people who created it sold it to surgeons, and surgeons said, no, this sucks, this doesn't work. So they said, okay, well, if you're not going to do it, we'll find somebody else to do it. So they went and found the pain management doctors. And the pain management doctors said, oh, how much do we get paid for it? And the mild people said, oh, you're going to make $1,000 bucks. And then the pain management doctor said, oh, that's a lot more than we make with an epidural. We make $100. So $1,000 bucks is better than $100 bucks. Let's do it. In summary, I don't believe in the technology. I've seen it, it doesn't work. I wouldn't do it on my patients because it doesn't work. And I don't believe in doing things that doesn't work. Unfortunately, a lot of doctors are in the mind frame, hey, let's do it because nothing works, but at least we did something. Let's just do it. You know what I mean? Like anarchy, free for all. You know what? Nothing really cures pain, so let's just do this. Because it sounds good, looks good. They got a nice video, they got a nice collateral marketing material. And most importantly, we're going to make some money doing it on patients, even though it doesn't work. But you know what? Nothing else works, so why not just do it? That's where we are today, folks, in pain management for spine pain. And it's a bad place to be. My opinion is surgeries should be done by surgeons, not pain management doctors. And, you know, the motivation has to be right to care for patients. It has to be, let's fix their problem. You know? All right. Shot? No. Oh, the last one. We are on the second to last one. And again, it's everybody's anatomy is different, but I can feel the probe slipping off of her spinous process, her transverse process. No, it's not because she's moving. It's just her anatomy. Shot? It's a pain in the ass to see. Shot. I think it needs to be, it's pretty close to where I need to be, but I'd like to be a little bit further down. Shot. God damn it, this thing is in the way. Switch sides. I can't stand that. Coker being in the wrong place. when I go across the patient. Shot. All right, so you can see the transverse process. I want to be a little bit more lateral. Shot. Shot. See, that looks good to me. And we just got to go a little deeper. That's it right there. I feel the TP. Shot. That's pretty darn good. Again, I'm feeling the mammillary process on the TP, between the TP and the facet. That's it. Let's go. That's two down, 2 to go on the right. Anyway, as you couldn't tell, I'm really against doctors doing treatments that don't work for patients. And nobody really wants a treatment that doesn't work. The problem is that the 99% of the world that treats back pain doesn't know about the Deuk laser disc repair. They don't know that it actually cures pain. So they're out there doing procedures that we all know won't cure pain because they think that there's nothing better. And they're offering patients things like the mild procedure, which is a terrible procedure. It may give you some temporary relief, but pain will come back because removing the ligaments is not solving the problem. And I don't even think that procedure removes the ligaments very well either. If you want to remove the ligaments, you need a real surgery. It's called a laminectomy foraminotomy, and that's done by a real surgeon. So this is kind of a half-assed procedure that doesn't work, the mild procedure. I would never do a mild procedure because they don't have good results, period. And I don't want to do a surgery on somebody that I know is not going to work. I have lots of people we turn away, you know, because they want something done that I don't believe it's going to help them. And I won't do something just because people want it done. I do it because I believe it's going to help them. It's going to fix their problem. These other treatments do fix their problem. The DPR, the Deuk laser disc repair for a bad disc, they do fix people's problems. The other treatments like mild don't. So it's just an ethical, moral decision that I made years ago that I wasn't going to do procedures that didn't actually work just to get money. So I'm burning the medial branch of the dorsal ramus. Once again, keep your eyes open for our new website, and when you see it, there will be a section on the discs, and there will be a section on the facet joints. And you can actually see on the discs where the annular tear happens, how it causes pain through inflammation. And on the facet joints, you'll see the tears in the capsule and how they cause pain and how we fix them. So it'll be really informative. All right, just about done with this. I got one more to go. Okay. So again, with this procedure called the Deuk plasma rhizotomy, we're basically killing a pain nerve to the facet joint in hopes that it gets rid of the pain, the arthritic pain patients get from arthritis in the facet joint. How do you get arthritis in your facet joint? Well, can you show us our target there? It literally comes from, arthritis in the facet joint comes from, or the pain in the facet joint comes from arthritis. Shot. A lot of scar tissue here, but that's the target right there. You guys see that? Right where the tip is. That little cleft. Yeah. All right, this will be our last one. We're going to be done in about 2 minutes. Are there questions the audience has for me about this or anything to do with the spine?
Yes, a question from Mike once more on YouTube. It was a follow-up question asking from the hypertrophic ligaments causing lumbar spinal stenosis. He asked, how would you fix that condition? And I believe that you answered unintentionally by saying laminectomy.
Well, yeah. So first of all, it's almost never the hypertrophic ligaments causing spinal stenosis. Okay, that's like me telling you, I don't know, the sun comes up every morning because you have grass on your lawn. They have nothing to do with each other. Okay, hypertrophic ligaments, they happen in everybody. Sean, everyone's got hypertrophic ligaments, let's face it. But they don't really cause the pinched nerves. What causes the pinched nerve is the herniated disc, the foraminal stenosis. It's not the hypertrophic ligaments. The hypertrophic ligaments could be removed in the back of your spine in order to get some pressure off the back of the nerve, but the real problem is the front of the nerve is getting pinched by a herniated disc. That's the real problem. And until you treat the herniation, you're never going to get rid of the real source of the problem. The real source of the problem being the nerve is being pinched from the front, not the back. So doctors will sell you on the idea of mild procedures, saying, oh yeah, we're going to get rid of hypertrophic ligaments. Okay? They'll even point on your MRI to the fact you have hypertrophic ligaments. Yes, but so does everybody. I have wrinkles on my face. If somebody took a picture of me and said, you have wrinkles on your face, I said, you're right, I have wrinkles on my face. But that doesn't mean it's causing my back pain. Okay? So just because you see something doesn't mean it's the source of the problem. And that's the issue, is that these doctors either don't understand the true source of the problem or they're lying to you. But in the end, why does the mild procedure fail all the time? Why do people who have it done, it doesn't work? The reason is because they're not targeting the true problem. Okay? So yeah, you can go strip out hypertrophic ligaments in your spine, but honestly, I've been doing these surgeries for 16 years, laser surgery. I don't touch the ligaments, okay? I don't touch them. They're still there, the hypertrophic ligaments, on every single patient I operate on. So why do my patients' back pain go away? Why does their leg pain go away? Because the real problem is the disc, not the hypertrophic ligament. But they show you the hypertrophic ligament, they sell you on the idea of hypertrophic ligament being the problem, and this mild procedure is a great way to deal with it, because that's how they make their money. They don't care about the fact that it doesn't work. Me, I care that my procedures work. If my procedure is not going to work, I won't do it. If you're going to pay me $50,000 to do something that I know is not going to work, I won't take your money. I won't do the procedure. That's just called ethics. I want my patients to be pain-free, so I focus on the things that cause problems. And hypertrophic ligaments. Louise, how often do we fix hypertrophic ligaments? Never. Right? Never. We don't. The only time we take out hypertrophic ligaments is when we do a fusion in the back of the spine. Go ahead. And that's because the hypertrophic ligaments are in our way. We have to remove them. Okay, but hypertrophic ligaments are located in the back of the foramen and the spinal canal. And everybody has them. And we don't deal anything with them, and yet we're curing everybody's back pain and leg symptoms. What does that tell you about the value of hypertrophic ligaments in the process of disease? It's minimal. If I say anything more, I'll be beating a dead horse. EBL, I'm going to call it 2 mils. What other questions do we have?
No current questions.
All right, we are done. We did a bilateral L3-4, 4-5, L5-S1, DPR, Deuk plasma rhizotomy for facet joint arthritis pain in a patient who injured her back and has had disc pain, which we fixed, and now facet pain. By the way, for those of you who are wondering, do the patients, how often do facets cause back pain or even referred pain into the thighs? It's about 10% of all chronic back pain comes from facet joint disease, 10%. Okay, we're working on compiling those numbers in a paper in a study we're doing. And right now, the head of our research, Arias Deuk, my son, going to Princeton next year. This is his big research project. It turns out, after reviewing over 2,000 patients that have come here, and these are pretty much consecutive patients, that 10% of their primary pain source in their back is the facet joints. The 83% is the disc. So I can tell you, 83% disc, 9% facets. He said piriformis and sacroiliac joint pain are roughly about the same, probably going to be somewhere around 3% each. Fractures and coccydynia, which is the coccygeal ligament pain, are the others. How often does hypertrophic ligaments cause back pain? 0. 0. We have 0 patients in 100,000 where hypertrophic ligaments caused back pain. So hopefully that helps. All right, have a great day. Thanks for watching, and we'll see you next week.